Okay, hi everyone. Thank you for joining us this evening. Today's tutorial is on anxiety disorders given by Dr. Tom Dalton. Just a few rules before we start. For those of you watching via the Zoom, if you have any questions covered in the moment, just pop them into the chat. If you have any questions that can wait till the end, just pop them into the Q&A. If you're watching on the Facebook Live, just comment your questions and we'll make sure that they're passed on. That's all from me, and I'll hand over to Dr. Dalton to begin. Thank you so much.
Thanks very much, Anel. So I shall start sharing my slides. As you probably know, today's talk is on anxiety disorders. Just to introduce myself, I'm a CT3 in psychiatry. I'm currently working in Hounslow on the liaison team. But I see anxiety disorders all the time, and probably will see them in, well, you definitely will see them in all branches of medicine. So it's pretty important to know about them, as we'll kind of talk about. Yeah, as we said, chat on any questions as we go along. I suppose I'll just start by saying, I think when I was a med student not too long ago, I remember anxiety disorders feeling like quite a dull topic. It feels a bit sort of run-of-the-mill, and we all know what anxiety is, so it's not that interesting. But I guess now that I've been working in psychiatry for a few years, it really has hit home kind of, it's a lot more important and I think a lot more interesting than I first thought as a med student. So hopefully we'll be able to catch your interest a little bit and also teach you the stuff that you need to know for med school, of course. So without further ado, on we go. Just a little disclaimer from becoming a doctor. Obviously, this is all my stuff, so any complaints, direct them to me. And these are our learning objectives for tonight. So obviously we're going to understand the etiology of anxiety disorders, how they come about, but also the phenomenology, which is it's a study of subjective experience. So basically what it's like to experience an anxiety disorder. We'll try and grapple with that a little bit because that's important when it comes really to understanding the etiology. And we'll look at the comprehensive presentations. This is stuff that you have to know for med school. And also talk about actually how anxiety really does kind of underlie a lot of conditions within psychiatry, and it's relevant to lots of general medicine as well. And then we'll talk about the treatment, of course. Just a quick question before we start. Oh yeah, it's just a minute. Fine. Okay, so on we go. Right, what is anxiety? Well, I'll start by saying, obviously, we all know what anxiety is, so perhaps this is not a very interesting question at first, but as you know, it's this constellation of sort of psychological and physiological responses to potential or uncertain threat. And I mean, I could list all the symptoms of anxiety, but you don't really need, like, you know that. It's kind of obvious. We know what anxiety feels like. A more interesting question, perhaps, is why is anxiety? Why do we experience anxiety? And I mean, the best way, I think, to understand it is it's analogous to pain. Pain is an experience that exists to motivate us to automatically withdraw from stuff that's tissue damaging. So we automatically withdraw without even having to think about it. It doesn't have to go through our frontal lobes. We just automatically withdraw from the candle flame or whatever it is that is causing us pain. Anxiety is very similar to that. It is an experience that we have the capacity to experience in order to motivate us automatically to avoid harm. That's the reason that we are able to experience anxiety, and it's fundamentally tied to avoiding harm and keeping us safe. As you can imagine, you know, it's a response to threat, so duh. But this is important when it comes to really understanding how anxiety disorders develop, that this is the basic function of anxiety. It's the whole reason it exists. But then, you know, this is all very well and good, but I think there's still a lot of confusion about exactly what is anxiety compared to all of the other words that we associate with anxiety, like how do you tease it all apart? Commonly, people ask, you know, what's the difference between anxiety and stress? You know, what do all of these terms sort of mean? So we'll try and unpick these a little bit as we go along, and please do ask if anything's not clear. And another kind of important thing to pick up on, I suppose, is what anxiety feels like, which again, we all know, but I think it's useful to sort of call that to mind a little bit as we go along today, to think about the experience of anxiety, because there are clues within that, within the normal anxiety that all of us remember and experience, as to how the disorder then develops. It's all rooted in everyone's normal experience of anxiety. So on we go, but hopefully that's, you know, setting out roughly what we're dealing with here. So what is anxiety disorder? Well, like any illness, of course, it's defined, there's too much of something and it's causing distress and impairment. that is obvious, I suppose. These are kind of the ICD-10 criteria for diagnosing an anxiety disorder. So the symptoms, which we'll go through in a bit, must meet those criteria. It's fairly run-of-the-mill stuff for a lot of illnesses, to be honest. And other things to bear in mind, these are the most common mental health conditions globally. They are very common. There's quite widely varying estimates for their lifetime prevalence, so how likely you are to have this over your whole life, because they're defined in all sorts of different ways in different countries, so, you know, widespread here. But these are very, very, very common disorders. You will see them all the time. They will be very commonly comorbid with whatever medical condition you're treating in your next patient. So it's important to know about them. And another thing is they're very highly stigmatized, and they get a kind of a different flavor of stigma perhaps to other mental health conditions. So something like psychosis or schizophrenia you might be quite scared of, and that's a particular sort of toxic kind of stigma that those patients face. But anxiety disorder has a kind of stigma around, you know, is this a real illness, or is this a person who's just essentially failing to cope with the normal slings and arrows of life? Because we all experience anxiety. We all know day to day what it's like to manage our own anxiety and not perhaps usually let it get on top of us. So we see someone with anxiety disorder and we may assume that that person is weak perhaps, or is less able to cope, and all these sort of things, these assumptions that we start to make, which is a particularly damaging kind of stigma when we think about some of the comorbidities of anxiety disorder. So hold that in mind as we go forward. But yeah, and sorry, this is just, so global burden of disease, obviously a big study of the global sort of impact of different diseases. And this is looking at years lived with disability. So it's not so much taking into account life expectancy and mortality, but it's certainly disability. And anxiety is big. Like, this is comparable to, you know, it's a similar size to diabetes. It's bigger than ischemic heart disease and stroke combined. It's a big problem. So just to kind of hammer that home, I suppose, with this lovely graphic that you get off the World Global Burden of Disease website. So how does anxiety disorder happen? Because there's a lot to think about here. It doesn't just randomly happen or happen because someone's not good at coping with anxiety. So it's quite an interesting question. And I think first it's important to look at some basic normal functions of the brain. Glibly titled, What is the brain for? Well, I'll give you 4 things that the brain is for. Firstly, to organize your sensory input, so all of the information that's constantly streaming in from your senses, to put that into sort of coherent fashion, and to assemble it into sort of models of the world, make sense of all this information, and, you know, you have an internal model of what the world is, and, you know, reality, whatever have you. So to make sense of all that information. And of course, one of the essential functions of any central nervous system, to motivate survival and to avoid harm. That's obvious. And also to try and do this in a vaguely efficient way. I've picked up on these 4 things because they are all relevant, I suppose. These normal basic functions of essentially any central nervous system are relevant to how anxiety disorder develops, and indeed many other mental illnesses. And another big thing that the brain is for, is all to do with adapting to your environment. The brain is the most astonishingly adaptive organ in the whole body. It's quite incredible. I mean, just think about how different our current, you know, Western society, the way we live now, is, how different that is to the environment the brain evolved to live in. So essentially, the hunter-gatherer environment that humans lived in for millions and millions of years, before really quite recently when everything changed. The brain hasn't changed evolutionarily in that time, and yet, miraculously, it is coping quite well with living in this way, and only 1/4 of us are neurotically miserable, which is pretty impressive. But yeah, the brain adapts constantly to its environment, and that is important when we think about anxiety disorder, and indeed many other disorders. So keep all these things in mind, and yes, also obviously I use a lot of memes. I hope that is helpful. Yeah, so I will kind of pick up on these different points as we go along, kind of bring them into the etiology of anxiety disorders. Right, so let's think about anxiety. Well, when we talk about anxiety, what we're probably talking about is state anxiety. So this is the state of being anxious. It feels, you know, we know what it feels like. We've all felt it before an exam, whatever have you. That's one kind of component of anxiety. But there's this other thing. Oh, yeah, and obviously it exists to motivate us to avoid harm. We've done that already, cool. There's also this thing called trait anxiety. Now this is a sort of stable personality trait, if you like. It's a stable characteristic of every brain that varies between individuals, and it's how much state anxiety you will experience under a given set of stresses. So, you know, how anxious you become when, you know, a given thing happens. So to give you an example, my two housemates in second year of med school, there was Lola and there was Richard. They were both medics along with me. Lola had quite high trait anxiety, so it took very little exam stress for her to be revising. She was basically revising from week 1 of med school because she, you know, felt the pressure of passing first year exams even. So someone with relatively high trait anxiety. Whereas Richard, more like me, he did not start revising until, I would say, less than a month before the exams. And it was all about the cramming. It took quite a high level of stress. The exams are now a month away before the state anxiety was sufficiently there to motivate him to avoid the harm of failing exams. I should add both of these people were very much within the normal range and both have become excellent doctors. So there'll be a wide range of different trait anxieties in any population pool. I should add here, we're talking about, this is all normal. We're not talking about disorder here really yet. In terms of how trait anxiety comes about, well, like anything, it's a combination of genetics and environment. So there are genetic factors which, you know, as you'd expect, and they're to do with serotonergic and noradrenergic function. You've probably heard of the monoamine hypotheses of anxiety and depression. So these are monoamines. So they're important neurotransmitters when it comes to anxiety and mood as well. But there's also environment, and environment is really important when it comes to trait anxiety, because basically what trait anxiety is a result of our adaptations to experiences of threat during our life. The more sort of threat you experience, particularly during development, because this is something that once you're 18-ish, maybe 25, this becomes fairly stable and it doesn't change a great deal over the rest of your life. But prior to that time, during development, you are adapting to kind of the level of risk in your environment, if you like. So experiences of threat, and particularly, you can get a bit complicated here talking about attachment, but that's kind of a really important thing during development, your attachment to sort of parent figures, which determines trait anxiety. Sadly, I don't really have time to go into it, but it's very, very interesting. Anyhow, those experiences modulate your trait anxiety, modulate your automatic threat response, because you've got to learn to survive in the environment in which you find yourself. If you're growing up in an environment which is quite persistently threatening and hostile, so maybe a household that's chaotic, with caregivers that are abusive, perhaps you've just experienced some traumatic things during your childhood, or just, you know, less massive stuff, but just, you know, some experiences of threat. You're going to want to adapt to that and make sure you can survive in that environment. And it may be that then as an adult, actually, you're no longer in a particularly threatening environment, but that doesn't matter. You've kind of calibrated your trait anxiety, your threat response in the environment you were developing in. So that's trait anxiety. Yeah, and it just varies a lot between people. People with a naturally high trait anxiety are more likely to have a high state anxiety. Now, state anxiety has various functions, which, oh, sorry, yes, obviously it's adaptive. There's the name again. A state anxiety has various functions, which are there, the purpose of state anxiety, essentially. This state causes the brain to do various things in order to keep itself safe. And these things are probably fairly obvious. So firstly is avoidance. Anxiety is all about avoiding harm. So naturally, state anxiety motivates us to avoid whatever we're frightened of. This is to do with keeping us safe. However, as you probably know from your basic psychology, if you have developed a conditioned fear of something, say it's to do with agoraphobia, being outside in wide open spaces, or social phobia, something like that. If you avoid, so you've started off with a fear of that thing related to whatever experiences you've had. If you have a bit of fear of that, and you then end up avoiding that situation, you don't unlearn that fear, and that fear sticks around, and you essentially believe that on an unconscious level, you believe that the only reason you're safe is because you've avoided that thing. Now, this is not really something someone chooses to do or happens deliberately. It's just an automatic function of anxiety. And it makes sense when you think about it, because say you, when you're developing, you meet a poisonous snake and it bites you and you get really ill. You're going to end up very frightened of snakes. And that's a good thing that you are therefore avoiding them for the rest of your life. And also it's a good thing that you don't easily forget that. You don't unlearn it unless you repeatedly meet loads of snakes and actually they're all really friendly and your brain gradually realizes that snakes are safe, for instance. It's not a good idea to easily unlearn this conditioned fear, because you only have to meet a poisonous snake once more in your life and that could be it and you could die. So the reason that sort of conditioned fear sticks around unless, you know, actually a concerted effort is made to unlearn it is perfectly sensible in evolutionary terms. So that's avoidance. Another thing that state anxiety does is it moderates the way that we sort of take in information and make sense of it. So anxiety leads to attentional and cognitive bias. So biases in the way we pay attention to different things in our environment, and also the way we make sense of those on a sort of cognitive level. So to give you an example, if you're walking home through a dark, scary wood, you will interpret the things around you in a more threatening way. Like you'll see shadows moving and you'll think, oh my goodness, is that a scary man about to jump out at me? Because you're in a state of anxiety, so you're primed to see threats in your environment. So again, useful, sensible safety behavior. However, again, this is gradually pushing us, this is all kind of normal functions of anxiety, but you imagine if you're starting to slide into anxiety disorder and you are not only being deprived of opportunities to unlearn conditioned fears of certain situations, you're also, when you're in those situations, more likely to perceive them as threatening, because this is all to do with what anxiety is for, what it automatically does for everyone. It's going to, again, make the state anxiety worse. We're getting some positive feedback loops here, which gradually drive the whole system out of its normal homeostasis and into a place that is disordered. And lastly, rumination is not actually the best word, really. I meant to change this slide. It's sort of more negative automatic thoughts, automatic negative thoughts, whatever. And these are automatically generating ways in which you could be threatened. So you're feeling anxious, so you're automatically thinking of bad things that could go wrong. We all know this about when you feel anxious, you worry. That's essentially a fancy term for worrying. And again, this is a function of anxiety because you want to be able to try and predict what bad thing might next be about to happen to you if you're in a situation that is threatening. Because this is state anxiety, is your brain assuming, right, the situation we're in is dangerous. What can we do to keep ourselves safe in that situation? So rumination is one of those things. And there is also an interference with sleep. And I don't need to tell you, I'm sure, that poor sleep has manifold consequences for basically every organ system, particularly mental health. You know, there are so many knock-on effects related to all sorts of things in terms of the function of sleep and the lack of that function if you're getting poor sleep. So again, I won't go into that really, you probably know a lot about it already. But we have here basically a self-sustaining system of positive feedback loops. And in order for anxiety disorder to develop, all you need is enough of these two things. Enough stresses and enough trait anxiety. And you push this whole system into a state where the state anxiety is making itself worse to an extent that it pushes itself out. You know, you're pushed out of your normal homeostasis, and you're stuck. Well, you're not actually stuck because anxiety disorder is very, very treatable. But before you have any treatment or before any of these things change, you're kind of stuck in this self-perpetuating network of positive feedback loops where the system is making itself worse. It's very like congestive cardiac failure, if you probably learned about that already. So that is exactly an analogous situation where basically, you know, obviously you have fluid overload and then that puts more pressure on the heart, so you have more fluid, and the whole system makes itself worse. But it makes itself worse through responses that normally are helpful. So the normal sort of baroreceptor responses in the kidneys retaining more fluid, all of those sorts of things that normally serve to keep blood pressure stable and to keep the body functioning normally. But when something is knocking the system too far off, so cardiac function is deteriorated to the point where it can't keep up, then those normally adaptive responses start actually making the problem worse and causing more harm. And this is exactly what happens in anxiety disorder. None of these are like choices that someone makes. None of these are to do with any kind of weakness or failure to cope or anything like that. It's all the brain doing exactly what it's meant to do, but things have pushed it too far to the point where actually those normally adaptive responses become a problem. I hope I've laboured that point enough, but I hope that sort of makes sense. It's really useful to get that clear, because I think if we don't have a grasp of this whole thing, we kind of just make some unhelpful assumptions about why anxiety disorder develops, why someone has developed an anxiety disorder, which then have knock-on damaging effects on our kind of therapeutic relationship with those patients, because we're assuming a bunch of not really true and not really helpful things about them. So yeah, grok this, make sense of it. And this is all basically based mostly on cognitive behavioural theory, on which cognitive behavioural therapy is based. So it's, you know, it's very well established kind of stuff. Do drop any questions as we go along if any of this is confusing, but I hope it's all fairly straightforward. I think you're probably aware of this already, but it's just kind of tying it all together. So on we go. Right. So another thing I meant to mention, I won't go through all of this. This is from another teaching session on depression, but it's really worth highlighting how anxiety and depression feed each other. Because the most common mental illness a GP sees, many of you will become GPs, the most common thing you will see is certainly the most common mental illness, probably one of the most common illnesses overall, is a combination of anxiety and depression. Because these two things rarely present completely in isolation. I mean, not that rarely, but very, very, very commonly, there'll be a mixture of the two. And you may give someone a diagnosis of depression if that's the kind of primary feature, but usually there'll be a lot of anxiety there as well. Or their primary presenting features may be anxiety, but actually there's a lot of low self-worth and low mood there as well. And I mean, these are fairly common sense things, I suppose. You know, if you have low self-worth, this is another feature of the way you have made sense of the world that you didn't. Nobody chooses to have low self-worth. It's it's one of the sort of facets of automatically making sense of the information you're given, if this is the information you're given. But this becomes a kind of stable, unconscious belief, if you like, a stable feature of your internal model of the world and yourself in it. And it changes your expectations about events. So you expect that you're not going to do well, and you expect you're going to be judged, and you expect, you know, we've all, I suppose, felt a bit low in ourselves, and probably, you know, unless you're supremely confident, we've all felt a bit like this. And sadly, I imagine many of us have really experienced the extremes of this, because depression is very, very common. And we know how this makes us feel and how it makes us more anxious, because when we go into any situation, we don't have, you know, I guess we don't have confidence in ourselves, whatever. Put it in all sorts of peppy terms like that. And then, of course, other ways that it feeds back. Poor sleep clearly causes low mood, and the avoidance has sort of feedback on, you know, social withdrawal, becoming more isolated, so it makes the anxiety worse, but it also worsens low self-worth and low self-mood. So this is basically a massive motor that just drives anxiety and depression. And it's, yeah, a sort of self-sustaining network of positive feedback loops. As I've said, it's a useful kind of framework to have in your mind, I suppose, because that's really it. I mean, you know, there's loads more if I was to really populate this diagram with everything we know about anxiety, depression, it would be as inscrutable as the metabolism of the cell. But, you know, these are kind of the most important things that, especially that you need to know at this level. Sorry, I've forgotten lots of my train of thought. This essentially is all there is to it. I mean, it's not all there is to it, but there's no magic. You know, we don't understand why mental illness develops. We don't understand why people become depressed. No, we broadly do. This is roughly how it happens. This is why people become anxious. It's not really a black box. Like, we do know this stuff, and you can know this stuff. I think a problem that psychiatry has is people feel that, you know, we don't understand the brain, therefore it's all a big mystery. But it's not. This is all you really need to know, particularly at your level. And this is all you need to help your patients. So I hope that is useful. Well, I'll talk a bit about the neurobiology, because obviously that's all cognitive behavioral stuff. I mean, really, the cognitive behavioral stuff on those previous slides is the most useful way to understand it, because it makes sense, it's very relatable, and you can use it to treat your patients. But there, you know, there are some interesting neurobiological things as well. Sort of correlates, obviously, is two sides of the same coin. It's not that the neurobiology causes the cognitions and the emotions, or the other way around. They are just two equally valid perspectives on the same process. But yeah, so some of the things that you see, and you might see this in sort of high trait anxiety or sort of prolonged anxiety disorder, is you have reduced functional connectivity between the prefrontal cortex and the limbic system. And basically this is to do with, this is your thinking, and this is your feeling things. Limbic system is where, like right here, this is the amygdala, roughly in the medial temporal lobe, where fear is sort of broad, I mean, it's distributed over lots of the system, but amygdala is sort of the center of fear. And essentially what this amounts to is it's harder to think your way out of states of anxiety. And this is a real key feature of particularly people who've experienced trauma. It kind of shuts down, the unsynophilic fasciculus is just one of many connections between the prefrontal cortex and the limbic system, which is kind of distributed over this whole area. But a thing that you see in people who have been traumatized is these sort of white matter tracts get a bit smaller, and there is you can literally see it on a brain scan that someone would be less able to really think their way out of states of anxiety and distress, which is often what many of us manage to do when we're, not having an anxiety disorder, but are just feeling anxious. But we can reassure ourselves and be like, no, it's okay. I've revised really hard for this exam. I do know my stuff. I don't need to be in a fog of panic. That's us thinking our way out of anxiety, and it's a thing that people normally learn to do quite well if they've had a sort of a normal upbringing, in inverted commas. But high trait anxiety, all of the things we kind of talked about already, can slightly sort of impair this connection. Other things that you see, so variations in serotonin transporters, and we've talked about that already. And then also dysregulation of the HPA axis. And this is the sort of the physiological side of anxiety. So your body, adrenaline, obviously, your body's response to threat. You get sort of dysregulation in this system. And it's, we know with anxiety and with anxiety disorders, you have lots and lots of, it's obviously not just a mental phenomenon, it's a whole body phenomenon. And you have all sorts of physical symptoms of anxiety, which I'm sure you're familiar with. So there we go. That's the neurobiology. I hope you're not letting you down too much by being quite brief on this, but I think the other stuff is essentially more important to be aware of. But I can answer any questions. Right, let's enable a poll. So hopefully you should now be able to go on the poll function and answer this question. Which of these following is not processes that should be processed. Which of the following is not a process which can be driven or exacerbated by state anxiety? Oh good, we're getting some votes in now. Fire away. I'll give it another, right, we know you're there, 6 people. We've got, if the last few people can just vote, I'll give you 10 more seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1. Anyone? No, okay. Oh, okay, one last voting. Right, I'm going to end the polling now. Right, this is not an easy question, to be fair. But the top one has come out as cognitive bias. Well, I'm afraid you are, so 2 of you have got this correct. The correct, oh, sorry, there we go, share results. That was what everyone said. The answer is trait anxiety. So, which I think a couple of people voted for. That is not something that is driven well, it's a tricky question actually. So state anxiety is a result of trait anxiety. You start with this, and this is a fairly stable thing, which then determines your levels of state anxiety. State anxiety causes all of these other things to be worse, essentially. But to be fair, if any of you voted for trait anxiety, I'll give you that actually, if you experience a lot of state anxiety when you're in development, that does exacerbate trait anxiety. So it's a slightly tricky question, but well done. On we go. Types of anxiety disorder. So there's a lot of information on the next few slides, and I'm not going to laboriously read through all of it, because you can all read, you'll get the slides afterwards, and it's just kind of a bunch of facts about different anxiety disorders. And at the end of the day, they look a bit different, but they're all fundamentally manifestations of the same kind of thing that we've just talked about, anxiety disorder in general. It can just take different shapes depending on different factors. But I'll whiz through these. You need to know these for exams, but I don't think there's much benefit of me just laboriously reading through it all. Generalized anxiety disorder, so this is kind of basically anxiety that's not specific to any situation. And it has all of these common features of anxiety, which I'm sure you will be pretty familiar with. So yeah, and this is straight out of ICD-10, so it's, you know, accurate stuff that you can hopefully use for revising in exams. And this is common. This is pretty common, and slightly more common in women than men. And you'll probably be quite aware of this as a diagnosis. And, you know, very, very commonly also associate comorbid with low mood. So that's GAD. I don't have a great deal more to say about it, really. That's what it looks like, and it comes about through the reasons that we've talked about previously. Then we have phobic anxiety disorders. So these are basically the same, except in a specific situation. So some of the things that we've talked about in terms of the etiology are a bit kind of more relevant or more easily understandable in this context. And the two that are actually relevant to doctors, to be honest, are agoraphobia and social phobia, because these are two things that people need to encounter in everyday life, being outside in crowds, whatever, and seeing other people. Those are essential to a normal life. The other specific phobias, you can have a great Greek lesson about different types of phobias, don't really tend to cause much of a problem. I mean, they sometimes can, particularly if it's, I don't know, someone's line of work interferes with it. But in general, you can avoid these situations and it doesn't cause you much of a problem in your life. So it's unlikely to meet the kind of criteria for an illness that it causes this significant impairment or distress. But agoraphobia and social phobia invariably do cause serious problems. And as I'm sure you can imagine, social phobia is very much feeds into the sort of depressive cycle that we saw earlier, but the reasons that are kind of obvious, and it's more common in men. Sorry, it's not. It's equally common in men and women. Agoraphobia is slightly more common in women. And yeah, these are some characteristic features you might need to, I mean, I don't know, this might be a bit too high level for your med school exams, to be fair. I certainly need to know this for MRC Psych, which I'm doing at the moment. But the fact that there's anticipatory anxiety about the event, and this is kind of relevant in terms of how it happens. It's not that you find yourself unable to go into the situation and try and unlearn that conditioned fear because you have so much anxiety that's there preventing you from going into that situation, anticipatory anxiety. And then sometimes you can feel anxious about becoming anxious, so particularly very, very, very anxious about kind of having all the physical manifestations of anxiety when you're in a crowd or when you're in a group of friends, because you'll be sweating and flushing, whatever it may be. So it's another sort of positive feedback loop. But, you know, hopefully this makes sense in the context of anxiety existing to motivate you to avoid the situation in the first place. And yeah, the somatic symptoms that we've mentioned. And these, I will hopefully do a whole other talk on medically unexplained symptoms and how they are related to anxiety. It's not a very, I'm going to say right now, even though it's not in that talk, medically unexplained symptoms is a big and really important topic to know about. I think it's one of the most important skills of a good doctor, is a good understanding of and a good approach to medically unexplained symptoms. And one thing I can say about it is that it's not all to do with anxiety, but a proportion of medically unexplained symptoms are related in some way to anxiety. So some of them, but not all of them. And you can see why. You get some features that might feel like a heart attack when you have anxiety. So right there you have anxiety causing things that will then make you even more anxious because you feel like you're having a heart attack, and on we go. Your symptom gets worse. But I'll save that for another talk. And again, these are common. These are very common. So that's what I'll say here. And then panic disorder is another, it's slightly less common, and this is more, again, slightly more common in women. And this is basically unpredictable episodes of acute severe anxiety, and has these kind of features. Again, very much in terms of being afraid of dying and losing control and feeling having a heart attack, all of that. And they're kind of unpredictable, which makes it even more sort of anxiety provoking. But again, really, all of these three disorders that I've just outlined are just slightly different shapes that anxiety disorder can have. Fundamentally, they're all really quite similar in terms of how they happen. But you do need to know kind of the differences between them. Right, that is a little natural pause, so I'll quickly check the chat for a question. How does panic disorder differ from generalized anxiety disorder, please? Yes, so panic disorder, you have these acute attacks. So they might last for 5, 10 minutes, half an hour, something like that. The rest of the time, you might worry about having an attack, but it's really the central feature of the disorder is that you have these attacks of really bad anxiety. Generalized anxiety disorder, you have persistent, as what's it called, free-floating anxiety that's just there all the time, basically. You are feeling constantly anxious, so it's spread out across your whole day, really. But it's a good question to ask because really, in reality, people will usually have, they might have something that meets the criteria for generalized anxiety disorder, but actually they do also have panic attacks. It's just that the panic attacks aren't the most central feature of their condition, so you tend to diagnose them with the first one. But this is why it's useful to think of them really as all different presentations of a similar pathology. And is agoraphobia a panic disorder or a phobia? So a bit of both. So it is a phobia because it's a fear that is specifically precipitated by a specific situation, being outside or being in crowds. However, people who have agoraphobia often experience panic attacks in that situation. So in answer to your question, it is a bit of both, really. I mean, technically it's a phobic anxiety disorder, but yeah, panic attacks, as you're probably aware, are a key feature. So keep the questions coming in and I'll answer them as we go along. Here's a quick quiz. So which of the following is not a feature of generalized anxiety disorder? And I hope I can, sorry. No, I don't do that. There we go, right, okay. I've launched polling for this question. So get your votes in now. There aren't too many of them, so I will give you 10 seconds starting from now. 9, 8, 7, 6, 5, 4, 3, 2, 1. Couple more people quickly voting. We've only got 6. Okay, fine. Well, another tricky question because I don't like to make the questions too easy. Most of you, oh yes, so 2 of you have got this correct. Sadly, most of you actually got it wrong, but it's a tricky question, so fair play. So you've all voted for short temper. So actually irritability, which is a technical term for the layman's sort of short temper, is a feature of generalized anxiety disorder. Not everyone with generalized anxiety disorder will have that feature, but it is a feature of that diagnosis. Low mood is not a feature of generalized anxiety disorder, technically under this definition. But I'm glad many of you have voted for it because you should be aware of it as something that is likely to be there as well. So it's not a feature of that specific diagnosis, but it is likely to be present. So in a sense, yeah, you're not wrong, but in terms of technicalities. So just pushing your knowledge to its limits there. Yeah, well done. Okay, right, another question here. There's content warning, there'll be a seed pod on the next slide, so if any of you don't like seed pods, look away now. And this is just a bit of a sort of a fun question, I suppose. How can I, wait, I'll just launch this poll. Right, polling 3, sorry, I'm very slow at this. Okay, poll is now open. And this is just a bit of fun really, because you don't need to know this for med school, I don't think. If you do, the person writing the exams should not be writing the exams, because it's not a very useful question. But which specific phobia may be triggered by this image? A few more seconds to vote. 3, 2, 1, and okay. You've by and large got this correct. This is trypophobia. Yeah. This is just a fun little break, really, to be honest, because it's not very important to know this, but I just thought it's interesting, and I like Greek. So ophidophobia is fear of snakes, xanthophobia is fear of the colour yellow. Oh, actually, to be fair, so if you'd voted for that, you wouldn't be wrong, because there is yellow in the image, I hadn't spotted that. Globophobia, apparently fear of balloons. This is getting a bit stupid and BuzzFeed-like. So anyway, trypophobia is fear of holes, and I guess probably, and I mean, I'm included in this, you get a bit of a disgust reaction to this image, and the reasons for that in terms of evolutionary terms sort of are probably related to kind of wasps' nests and things that are dangerous related to insect life, perhaps, that are, yeah, harmful, and therefore you have an automatic shy away from them. But I guess the point I'm trying to make is all of these phobias, well, okay, not all of them, probably not xanthophobia, but many of the common phobias, particularly fear of snakes, arachnophobia, fear of spiders, and even trypophobia, fear of weird holes, they do have everyone will have that to an extent. They will have a bit of a reaction to that because it is built in our evolution. And someone who experiences a really severe phobia, I mean, particularly if it's causing them problems in their day-to-day life, it's just, I suppose, more of an extreme of something that is fundamentally normal and that we all have. Nomophobia, I didn't mention this. It's an odd one out because it's not real Greek. Short for no mobile phobia, and it is anxiety related to not having a mobile phone. I don't think it's a real thing. Anyway, no, I dismiss it out of hand, but there we go, that's that. Right, on we go with some actual useful stuff. Treatment of anxiety disorder. And this, I hope, will make a lot of sense in the context of what we've talked about already. So, think about this diagram that basically sums up how anxiety is happening and how anxiety disorder is maintaining itself. And we have stepped care for anxiety disorder. So basically, depending on how severe the anxiety disorder is, we'll meet it with an appropriate level of intervention. For mild anxiety disorder, these things are, and to be honest, for every anxiety disorder, these things are very, very useful. But you can get by on these alone for mild anxiety disorder. So psychoeducation, becoming aware of these kinds of cycles and how, particularly avoidance, because that's just a really big one, how that can worsen state anxiety. And, education around the fact that this is an inbuilt evolutionary response that is just your brain trying to survive. So it's not your fault. So you're trying to avoid feeding the low self. Because I think telling you, oh, you're making your anxiety worse by avoiding this situation is just going to make people feel worse about themselves. And that doesn't help anyone, as we know. And this is an automatic thing that the brain is doing. So emphasizing that. But, so it's all happening automatically. And it's not your fault. It's this thing that every brain does. However, in your case, because we've got too much of this and too much of this, it's pushing the system into a state where you're really having problems with your anxiety. So we really need to focus on this and work on this, because this will make the problem better if you break that loop. Sleep hygiene, obviously, is so important. And I won't go into kind of all the details of that, but hopefully you will learn about it, or you'll know about it already. This is just basically measures to improve sleep, and there are all sorts of things in the way we live, most of us, which further contribute to poor sleep, never mind if we have an anxiety disorder. And if you address some of those other issues that may be interfering with sleep, you can again break this positive feedback loop and improve the whole situation. And then self-guided CBT and relaxation exercises. So these are to do with finding ways to get your way out of state anxiety, to, relaxation, sort of meditative exercises are a very good way for someone to reduce their own state anxiety. It's not easy, and it's hard enough, I think, to focus your mind and meditate, whatever, relax, when you're not feeling anxious. When you're feeling anxious, it's really, really hard. And I think we can often feel a bit dismissed. Patients can often feel a bit dismissed if you don't, it's all about, relaxation, chill, meditate, whatever. And it sounds easy and it sounds glib and it sounds just like something you see on a motivational poster on Facebook. But it's difficult, but it is very effective. And self-guided CBT is to do with kind of trying to break all of these cognitive feedback loops, these sort of cognitive errors that you make because you're in a state of anxiety. So that's mild, and these are all things that are really, really good. So they are very useful for anyone with any anxiety disorder. However, with moderate or severe anxiety disorder, you're going to maybe also want some more heavyweight things. So CBT, this is usually, you might have individual CBT, a cognitive behavioral therapy. And this is basically a therapy that's based on the theory that I got this picture from. I drew this picture, so it's not, take it with a pinch of salt. It's just what I've plucked out of my brain. But these are all well-established cognitive behavioral theoretical theories, whatever. And cognitive behavioral therapy is a therapy basically just based on those theories and undoing some of these positive feedback loops. Exposure therapy is basically the way to tackle avoidance. You expose yourself in a gradiated way to the thing that makes you anxious. And that's really hard because you're doing exactly what your brain doesn't want you to do. You're going against your survival impulse. And that is a very, very, very difficult thing to do. So you do it gradually. Just a picture of a spider first, for instance, if we're talking about arachnophobia, and then a spider in the other side of the room, whatever it may be. That's an obvious example. And there we go. And then the pharmacological treatments, which you need to know from med school, they're kind of equal first line with CBT. Generally, CBT is going to actually solve the problem, and pharmacological treatments are going to make it easier to do this work, because this is hard, and pharmacological treatments take the pressure off, if you like. They directly reduce the state anxiety a bit. and they therefore make it easier to undo these loops. But ultimately, if you're just having the medication, I mean, that some people do just manage anxiety with the medication only, and that works. I suppose the most effective thing is a combination of the two. And you're going to use a specific serotonin reuptake inhibitor, or a serotonin noradrenaline reuptake inhibitor. I've not provided lists of these, but you know, sertraline, citalopram, escitalopram, fluoxetine, paroxetine, all of those ones, and other antidepressants are also useful. So that's your first line. If you get into the nitty-gritty, sometimes there are particular antidepressants that are recommended for particular types of anxiety disorder, but I don't think you really need to know that as a med school. But yeah, you try one, and then if that doesn't work, you try another one. You can consider combining them. There's not great evidence for that. It's usually getting to the point where you'd be talking to a psychiatrist about that if these aren't working. But for various reasons to do with us not understanding how the brain works, one SSRI might not work for someone, but then a different one might work. And we don't fully understand why that is, but it's worth trying several. So there we go. These are the treatments, and they're all good. And ultimately, anxiety disorders are really treatable. Like, we don't need to feel this is something we can't deal with. We can. The difficult thing is that it does involve a lot of things that are really hard to do, because quite often you find that the medication can help quite a lot, and maybe it can help someone function normally and actually manage it, but quite often the medication alone isn't enough, and it takes some of these things which are really very difficult for anybody to do. And you know, it's hard enough just to do sleep hygiene, which we should all try to do. But yeah, it is very treatable, particularly if these sort of treatments are adhered to well. And it's all about motivating your patients to engage with them, and that's all about psychoeducation. So right from the top of that list. Okay, on we go to other related disorders, and we've got 15 minutes to kind of cover these, so I'm going to be very brief because I think we've done now the most important subject matter for kind of anxiety disorders, but there are some other things which, for instance, OCD and PTSD used to be classed as anxiety disorders. They're actually a separate sort of class now in the latest sort of diagnostic manuals, but they're clearly relevant. Eating disorders also very relevant. Complex PTSD, I only touch on briefly, very interesting. Right, well, without further ado, and I'm going to be quite brief with this because it's not just PTSD, but you know, as we know, PTSD, post-traumatic stress disorder, it is something that can develop following exposure to really horrific event, such as war, such as a car crash, such as abuse, whatever it may be. There's theories that it's to do with impaired memory consolidation because that event is so traumatic and so extreme, it exceeds your, you know, anyone's capacity to kind of cope with it and process it normally. And so the memory is not sort of encoded and stored in a normal way because the event was too extreme to be able to do that. And therefore the memory is kind of, there are all sorts of theories about the way the memory is stored and how it sort of obviously keeps intruding back into the person's life in an abnormal way. Yeah, it's quite an interesting sort of feature. And in terms of the features of PTSD, and I think this is something that I did have to know for my PACES, OSCEs at the end of med school. It's not too hard to remember with the acronym, sorry, mnemonic, hard. Hyperarousal, so this is feeling basically tense and anxious all the time. It's that state anxiety where you're constantly alert for dangers because you've experienced this incredibly horrific, threatening thing. So clearly your brain's going to be therefore calibrated to a higher level of sort of trait anxiety, if you like. Avoidance is and naturally that makes sense in terms of everything that we've talked about. Re-experiencing, and this is what are called flashbacks, and they are, as you probably are aware, kind of incredibly real, feels like you're there again, kind of experiences of the traumatic event. And nightmares is also included in this, and distress. Naturally, all of these things are really, really distressing. The features, and it's, you know, it's not as common as the other anxiety disorders, but it's not that rare really. And the treatment basically is quite similar to the treatment for anxiety disorders generally. So you have CBT again, but it's kind of trauma focused specifically. EMDR is an interesting new therapy that's on the scene now, which seems to be very effective for PTSD. And I don't really have time to explore why that is. It's quite an interesting one. Have a little read about it if you're interested. I'm sure you're all interesting. And then the above things are always useful for every anxiety disorder. They are never not a good thing to do. So I'll just remind you of that. So that's PTSD. Then we have OCD. Now I think OCD, we think of these sorts of things when we think of OCD. And I get very angry when, you know, people using OCD in this sort of flippant way to basically imply fastidiousness. That is not OCD, as I hope many of you are probably aware, because actually mental health awareness is getting better and better year on year. So you probably don't really think this anymore. You're probably aware that obsessive compulsive disorder is a really quite a nasty mental illness. It's very, very unpleasant, and it often presents quite severe at the point of kind of presenting to a doctor. I mean, all of these disorders that we talked about are nasty. I don't want to belittle any of the others, but OCD is a horrible one, I can tell you. It's characterized by intrusive thoughts. So a particular feature, as we talked about, of state anxiety is, you know, generating possible threats and bad things that could happen. And basically OCD is a kind of particular overdevelopment of this feature. You have these constant, really unpleasant thoughts about something awful happening. And it's not like someone's putting thoughts into your head, like in psychosis. It's not that. So that's a key thing to ask if you get this in an OSCE or a PACES, whatever. And you can't control the thoughts, and you want to. So obsessive, you might think of being obsessed with something in a good way, like, oh, I'm obsessed with my stamp collection, whatever. That's not what we're talking about here. Obsession in a psychiatric context is these intrusive thoughts that are involuntary. And then the other side of it is you have these compulsive behaviors, which basically serve to relieve the state of anxiety and tension that is driven by the intrusive thoughts. So this causes this, essentially, is a simplistic way of putting it. And here's another pretty picture that I won't go through in too much detail. But you have these obsessions. Often this is about something awful happening, your whole family dying, or whatever it may be. And sometimes it's more to do with a sense that something is wrong and things need to be a certain way, and that maybe gets a bit closer to the kind of popular conception of OCD as fastidiousness. Anyway, and this is sort of a self-feeding cycle of sort of rumination and negative automatic thoughts, as we talked about. You get this state of distress and anxiety, and this drives the behavior. So many different compulsions that you get in OCD. Hand washing is like the classic one, driven often by a fear of catching a disease, but there are many, many others. And then this is a really useful cycle to kind of be aware of. You get a temporary relief when you do that thing from this state of distress. And something important happens at that point. You obviously think to yourself, oh, I feel a bit better now that I've washed my hands. I've reassured myself that my hands are clean, and that makes me feel better. But at an unconscious level in your limbic system, basically, your brain is learning that whatever you just did made you feel less anxious. And that is called negative reinforcement, and it basically drives you to repeat that behavior. So quite apart from you deciding that was a good thing to do, I'll do it again, you have an urge to do that thing from an unconscious learning process, basically. Your primitive survival systems in your brain are driving you to repeat that behavior because whatever you did made you feel more safe, and that is fundamentally what your limbic system is driving you to do. And repeating that over and over and over and over again drives compulsion. It becomes compulsive, basically, and that means you can't control it. You are not able to not do this thing. You have to do it because this urge is overwhelming. And actually, the interesting, so I'll talk about that a bit more in just a second. So a few more facts about OCD. Generally, it's not uncommon. So like, this is more common than, like, I don't know, Crohn's disease, for instance. It's something that you learn a lot about in med school, and it's often extremely debilitating. So it is an important condition to know about and not miss. There are some specific treatments. So there are particular SSRIs and actually also tricyclic antidepressants like clomipramine, which are particularly useful for OCD. And there's a particular type of CBT that's useful for OCD. So if you see someone with things like this, you might be thinking, oh, this is just an anxiety disorder. But actually, if you pick up some of these sort of intrusive thought kind of features, you might be able to start them on specific treatment for OCD. And this will often be treated in secondary care because, as I said, it's difficult to treat. This kind of cycle actually isn't just relevant to OCD, it's relevant to self-harm, it's relevant to substance use, addiction, also disordered eating, that you basically, you feel distressed, anxious, tense, whatever it may be, low mood all the time. This is a persistent state that's there all the time, and there's something you're able to do that temporarily reduces it, gives you a relief from that thing. And this cycle is very relevant to kind of all of these kind of disorders and more. And it's important because I think we can see patients who can't stop using heroin or won't stop compulsively injuring themselves or won't eat normally, whatever. And we're just, why don't you just do the thing or stop doing the thing? Why are you keeping doing this? Because you know that it's harming yourself and that it's disordering your life, disturbing lots of stuff in your life, and it's causing all sorts of problems and actually making your state of distress worse. Why don't you stop? And it's really important to realize what compulsion is, and the fact that it's a state where you are unable to stop. It's too difficult. It is unreasonable to expect that person to just stop. I have a whole other talk on compulsion and compulsive disorders, which I don't have time for today, but just be aware of this. Anyway, going on. Eating disorders, I'm just gonna, there's loads to say about eating disorders, which is a whole other talk in itself that I'm not gonna do today, but the takeaway message that I just wanna leave you with is they are, by and large, driven ultimately by anxiety and low self-worth. They are driven by these things, and they are these negative states are kind of experienced as I look wrong in some way, and they result in the disordered eating behaviors that, again, like the stuff we've talked about already, reinforce themselves through negative reinforcement and through all these things. But the really important thing is that the key function of anxiety within eating disorders. Again, that's another talk, which maybe we can do another time. And lastly, very briefly, in the last few minutes, we've got complex PTSD, which is such an interesting topic that I will not be able to do justice to. But essentially, this is where you have a series of extremely threatening, horrific events, often during development. And yeah, typically a feature is that escape is difficult from them. And you have a whole load of modifications to your automatic threat response, and we're talking about trait anxiety here. So you really do adapt to these prolonged experiences of threat to the point where your trait anxiety and your sort of whole threat response system is changed in order to try and survive these traumatic events. And this has a whole load of interesting features that are more than just anxiety. And they're to do with the way you're able to regulate your mood. And very commonly, low self-worth is a really big feature of these. All sorts of features that you associate with depression. And also difficulties in relationships and feeling close to others. Now, the really savvy among you may be thinking, this looks a little bit like something I've heard of called emotionally unstable personality disorder. And you might be right. So this is, I think, possibly a better way to try and describe this thing we know as EUPD, which, if you don't know about it yet, I will hopefully do another talk on it if Becoming a Doctor let me. It's a fascinating and really important thing to know about within medicine, which is very, very heavily stigmatized, hugely, particularly within healthcare. And it's partly because personality disorder, you're the problem, is what you hear there. And complex PTSD is perhaps a more truthful way to describe it. Anyway, I'll whet your appetites with that interesting little tidbit, and I'll have to leave that for today because we don't have time. Anxiety is everything. But anxiety has a role in so many different psychiatric disorders. I don't know where to start, and I hope I've hinted at that as we go. But anxiety kind of governs much of what humans do, to be honest, because the need to survive is obviously fundamental. And actually, I could go a whole down an interesting road of the psychodynamics and how all of that's driven by, all of this Freudian interesting stuff. A lot of it is driven by anxiety. But yeah, anxiety is just one of the central functions of the brain, and it drives a huge amount of normal behavior as well as abnormal sort of things that you see in psychiatry. So it's important to kind of understand the basics of anxiety because it is everywhere, it is everything. Don't miss it. Right, a little quick quiz before we finish, and if I can, sorry, I'm just going to have to faff again with the call function while I work out how to use it. Why am I so bad at this? I'm sorry. Right, here we go. I've launched the polling for this quiz. What would be the most appropriate treatment for moderate social anxiety disorder? And I'm interested to see your answers for this one. So I'll give you 10 seconds because we're quite short of time. 8, 7, 6, 5, 4, 3, 2, 1, lovely, and I'll end the polling there, and a really good spread of answers, which I'm delighted to see. So most of you voted for self-guided CBT. You've said psychoeducate. I'm disappointed nobody said sleep hygiene advice, because that is also a good treatment. So again, I've done a little bit of a devil in the detail question, because I like doing those, just because that's the kind of thing you might get caught out in exams. So technically, the answer here, which not many of you voted for, is to start this citalopram, because you have moderate social anxiety disorder. So in our stepped care model, the moderate disorders, you're going to be thinking about CBT and pharmacological treatments. And CBT, so we're talking individual CBT, is not one of the options, but it is the best one. So if that was there, that would have been the right answer. So you're left with, and sometimes people refuse to have CBT, and sometimes, unfortunately, it's not available, or there's a really, really long waiting list. So your option as a GP when someone comes to you with moderate social anxiety disorder is to start escitalopram. However, I'm glad many of you voted for these other options because they are always useful, as I keep saying. So in a way, none of you are incorrect, really. Right. Last thing I'll say is about anxiety in medical students, because it is super common. There's studies showing about 30% of medical students experience anxiety that sort of pushes into the kind of anxiety disorder territory. And I mean, obviously it does, because we do a job that's really, really stressful. And, you know, we are the doctors, but who cares for us kind of thing. I don't really need to tell you that, I suppose. But I guess being aware that this is common. And also being aware there are things you can do to reduce the likelihood of it becoming a serious problem. All the stuff we talked about, as I said, all those basic steps for mild anxiety are always useful for anyone, whether you have no anxiety disorder or severe anxiety disorder. They're always useful. But that doesn't mean if you have an anxiety disorder, it's your fault because you didn't do those things. Because as I keep saying, those things are fundamentally counterintuitive at an evolutionary level. They're going against your fundamental drives to survive, to stop avoiding that situation or whatever have you. So it is the absolutely natural thing to do sometimes, really, to develop anxiety disorder when you're in certain situations. So it's important to counterbalance these two things. There are things you can do about it. However, they're difficult, and you are not to blame for developing that disorder because you didn't do those things good enough, because nobody knows how hard those things are except you. So I'd really like to emphasize that, because I think you get caught in a rock and a hard place with kind of mental health awareness. Firstly, that like, it's not your fault, it's an illness, it's just like getting the flu, you are not to blame for this thing that's happened to you. And also do all this stuff that'll make your depression and anxiety better. And it's like, well, if I've got depression and anxiety, therefore it's because I didn't do all that stuff, or I can't help myself at all because it's something that's happened to me and there's nothing I can do about it. Those are the sort of two lies that we fall between, I guess, with the kind of lots of mainstream awareness of common mental illnesses. So I think it's important to hold these two things in tension. And hopefully you'll get all these slides and you can look into some of these resources. But it is really, really important to know that, you know, help and advice is there, and speaking to your GP is always going to be a good idea if you think you're experiencing some of the stuff that we've talked about today, really. And I think that can be a really difficult thing to do sometimes. I'll leave that there. Right, and the takeaway messages, which I will just quickly go through, and then I've got a few questions in the chat. So firstly, these are really, really common problems. They really suck. They're really nasty. They are not something to be dismissed or taken lightly or stigmatized as just not coping really well. And they are simply a result of doing what evolution tells you to do. They are the natural thing to do. And it's really important to remember that and to tell your patients that, because of the low self-worth side of it. They can be effectively treated, but don't forget how difficult that is. And just anxiety is life. Anxiety is everywhere. Go forth and be anxious, but not too anxious if you can help it. Right, I will leave you now with the feedback code, and while you're all please scanning that and leaving some feedback to feed my ever-hungry portfolio for my reg applications, I will answer some of the questions that have popped up on the chat. So, we have question from Facebook: how long would you generally continue the pharmacological treatment once? And also, apologies that I'm running over by a couple of minutes. I'll just do a few questions and then I'll finish. So, interrupted myself there. How long would you generally consider continue the pharmacological treatment for once symptoms have settled? Good question, and actually, I don't know off the top of my head. No, I do know that's not true. So ballpark, I guess, it's useful to continue it past when the symptoms have abated, and think about continuing it, you know, for a good few months. Thinking about how actually all those self-sustaining feedback loops that are really driving the disorder may well still be there and may not have gone away completely. The medication makes it easier to do that work and bite that bite and undo some of that sort of spiraling. But if you stop the medication as soon as the symptoms go away, you may fall back into that spiral. But if you give yourself long enough to properly get yourself out of it, then you can be on sort of solid ground. So really the answer is a bit woolly, but I think sort of, maybe 6 months-ish, or until you're really in the clear from an anxiety point of view. And it's, I'm sorry that I don't know the exact NICE guideline recommended amount of time. I think in reality, it's best to make the decision on a case-by-case basis, in terms of, whether someone's really happy taking them, or, whether they think, actually, I want to keep taking this because it's keeping me really well. That's an absolutely fine thing to do, because these medications are pretty well tolerated and they're okay to take long-term. There aren't really many long-term risks with them. But equally, someone might want to stop taking them quite soon, and that's also okay. Right. Oh yeah, and that question has also been asked on the chat. So I think that's all the questions we have. Please do, as I said, do the feedback, which I will leave up just for another minute or so. But yeah, I will hand over to Hinal to kind of close up. And I'm happy for Becoming a Doctor to pass on my email address to you guys if you have any more specific questions. More than happy to help there. So that's all from me. I don't know if Hinal's going to close off the talk. No, fine.